Good evening. Good evening to you all. I hope you are all well and you are in good health. Today we're privileged to have Professor Nicola Sforza. I hope I got the pronunciation well. Professor Sforza is from Italia, and he did his degree in dentistry from the University of Bologna. Professor Sforza was a professor at the University of Bologna for so many years, as well as the University of Turin. Currently, he is the professor of periodontology at the University of Florence. He is also the current president of the Society of Periodontology and Implantology in Italy. So, ladies and gentlemen, please allow me to introduce our professor who's going to give us a talk on the management of post-extraction site for implant therapy. Professor, this is your time.
Thank you, doctor. And if you want, I can share with you the screen so we can start it.
Yeah, sure. We would appreciate that.
Okay, is okay for you?
Yes, it's okay.
Okay. So, dear colleagues, good evening, and thank you for being here for this lesson. Really, I'm glad to be here with you. Please, sorry for my not very fluent English. However, I hope to be able to speak so that you can understand me. So now I at the moment I am in Italy, in Cervia, close to Rimini, spending my summer vacation at the sea with my family, and tomorrow I'm going to the mountain and in Trentino for the last days out of the work. First of all, let me thank a few people. The first person is Massimo Vigani for what he does every day in Zimbabwe and in his life. I have to thank him also for having been in Italy last March at the National Congress of CDP in Rimini. His lecture was very appreciated by almost 2,000 participants, and there he explained to everyone that it's possible to do quality in dentistry and in medicine by optimizing the existing resources with competence, organization, passion, and generosity. And the generosity is a very great gift, and I wish to declare that many people in CDP are ready to come there to Zimbabwe for cooperating and helping Massimo and his team and ZiDA for teaching, helping in clinical activity, and with donations in form of instruments, equipments, and financial resources. It will be my obligation in the next future as president in this future 2 years of Italian Society of Periodontology and Implantology. The second person who I want to thank is Mauro Merli, that you know very well for his friendship, for helping me during my presidency of CDP, and for suggesting me to invite to Massimo last year in Italy. And obviously, I want to thank Dr. Tsibonda, president of ZiDA, and all the board, and also the Dr. Vicky Chaperson as of the Professional Development Committee for the kind invitation. And now we can start the lesson. The topic is the management of post-extraction site for implant therapy. And we are talking about a very topic issue that during last years has been presenting in many clinical trials. When we decided to extract a tooth and substitute it with a dental implant, as clinicians, we have a great responsibility. Why? Because we know that dental implants, although a high predictability, currently don't have a better long-term prognosis than teeth. And the truth is that in implant therapy, there are a few failures and more complications, especially biological complications like mucositis and periimplantitis. And the topic of the problem is that although the high prevalence, therapy of periimplantitis is not simple, not predictable with the available options to the clinicians. And that include, as we know, the non-surgical and resective or regenerative surgical therapy. But on the other hand, when we decide to extract a tooth and we have a great opportunity for us and for our patient from the implant therapy point of view, because we can decide timing and clinical strategy of implant post-extractive insertion. And this is possible in terms of comfort of the patient, for example, reducing the time without chewing function and with aesthetic problem, anticipating the time of implant insertion after the tooth extraction, and reducing, obviously, the cumulative treatment time for the new function and aesthetical. And also in terms of reducing financial costs, because less total chair time means less costs. In the last consensus of the IFP published in 2019, we can recognize...
Professor, to disturb you. Sorry, Professor,
Sorry?
to disturb you. I'm sorry to disturb you. Would you mind sharing your screen?
Okay, don't you see it?
Yeah, we can't see the screen right now. Yeah, we can't see the screen.
It's okay?
No, not yet.
Non ancora? Okay. Okay, sorry.
It's all right, Professor. Yeah, we can see the screen now.
Okay.
Yes.
Okay. Sorry for this. I didn't understand it. Okay.
It's okay.
So,
it's all right.
It's okay now? Is okay now?
Yes, everything is okay now.
Okay. So we can recognize in the last consensus of the FP published in 2019 that available options for implant placement after tooth extractions are different. So we can insert an immediate implant, post-extractive implant type 1, and without or with immediate bone regeneration, or alternatively, we can retract the tooth in an automatic modality and apply an alveolar ridge preservation or reconstruction, postponing the implant insertion after a few months. One more option is waiting for a partial post-extractive site healing, only soft tissue, inserting a type 2 implant after 4-8 weeks, or waiting for a partial bone healing within 3 or 4 months, type 3, or still waiting for full bone healing after 4 months from tooth extraction, type 4. In all situations, bone augmentation could be required depending on post-extractive site conditions. Certainly, the choice of post-extractive implants among different clinical options is influenced not only by scientific evidence about predictability of different procedures, but also by extraclinical factors referred to the patient, to the extraction site, and to the clinician preferences. So, from the site point of view, the surgeon decision can be different depending on if the post-extractive area, for example, is at a molar or aesthetic area, is the post-extractive site undamaged or compromised, and at last, is a chronic or acute infection present or not? Certainly, nowadays, when we personally can decide when and how to extract a tooth, it's totally irrational to insert a late implant, and this concept is clear since the ITI consensus in 2014. Why? Because when we wait for the complete bone healing at the post-extractive site, very often we have to do a regenerative approach during or before the implant insertion. And this approach requires more time, more experience, professional ability, more possible complication, and economical costs for the patient. And so, this is an example case. Laura, female, 36 years old, and with no systemic diseases or risk factors, no smokers, and without periodontal disease. Came to my office a few years ago. After almost 8 months before the extraction of the 2.4 tooth by her previous dentist. Why was my clinical approach? It was a prosthetic-driven implant insertion using piezo surgery, and in a damage and reduce implant site with a very pronounced horizontal defect. In this case, I use a regenerative approach with a particulate bone graft, combining autogenous and demineralized, deproteinized bovine bone in a 50-50 proportion. And the graft applied in sex has been covered by a collagenic membrane, very hardly fixed to the site with mini nails, and the flaps closed on the biomaterials and in a passive way, sutured without stretching it. And after 6 months, I discovered the implant applying a periodontal mucogingival approach to increase the peri-implant tissue thickness with a combined technique, including a modified mini roll technique and a connective graft taken off the palate of the patient. And then applied a temporary crown a few hours later, and I have been waited for the stability of the soft tissue healing for almost 6 months ago again. And finally, 18 months after the implant insertion, we can see the results. And the crown applied, and with a good result and satisfaction for my patients and for myself, but also obviously with a long-time therapy, many economical costs, and a lot of risk of complications. So, when we can decide the strategy, the late implant is reserved only in very limited situations, referring to the patients or to the post-extractive side. To the patients, the situation is when we have young adolescent patients who have lost one or more teeth, too young for implants, or pregnant women, patients would need to postpone implant insertion due to economical or personal needs. Or to the sides, for example, large cystic lesions or advanced site destruction, like in this case, in which I have removed both an implant with severe perimplantitis and the mesial adjacent tooth with a large root vertical fracture. After the extraction, inserting an immediate or early post-extractive implant wouldn't have been possible. In these cases, when there are indications for late implant, as published 8 years ago, the consensus ITI recommends doing an alveolar ridge preservation procedure, not to prevent the bone atrophy of the post-extraction site, but to reduce it and to reduce the necessity of more complex augmentation techniques during or post-implant insertion too. So, in this case, I waited for the complete healing of a site 6 months after an alveolar ridge preservation technique, and then I simply inserted 2 one-stage implants, always prosthetically driven, reducing dramatically the difficulty of next surgical approach and the need of a very complex hard and soft tissue surgery. Talking about post-extraction site atrophy, I want to quote this systematic review by Toll and co-workers published in 2012. In this research, 20 human studies have been evaluated, prospective or RCT, and with a follow-up of at least 1 year. The authors have noticed that the bone resorption starts immediately after extraction, is significant after 3 months from the tooth extraction, then it is less but progressive, and as at buccal position it is higher than at lingual site, and at molar site it is higher than at premolar site. Moreover, after 1 year, the bone resorption is more horizontal than vertical, with a ponderate average of 50% in horizontal plane, respect 15% in vertical plane. In addition, bone resorption has great variability among patients and proportionally to genetic and individual risk factor like smoking, for example, systemic diseases, previous periodontal disease, occlusal skin. But another crucial factor for resorption pattern, because it's able to influence cloth stability, is the integrity of a post-extractive site. Obviously, when we don't have a buccal cortical plate, or the pattern of the bone resorption will be different and greater than at a complete and thick site. And definitively, the buccal cortical bone thickness, then especially in aesthetic area, is very thin, can shape the post-extraction bone resorption pattern. Vivian Chapuis, in 2013, published a clinical trial focused on 39 patients at 8 weeks with a three-dimensional X-ray analysis on post-extraction sockets in the maxillary anterior area. She compared the first CBCT immediately post-extraction of a maxillary incisor without any alveolar preservation technique, obviously, with the second CBCT after 8 weeks and measured the crest modifications with the superimposed bone surface model generated by CBCT. The results have been that if the bone wall was thicker than 1 millimeter after 8 weeks, the horizontal resorption was 0, and vertical resorption was with an average of less of 10%, less than 1 millimeter. Instead, if the bone wall was less than 1 millimeter, there was a bone reduction after 8 weeks, about 10% at horizontal plane, with about 60%, average 7.5 millimeters at vertical plane. It means that almost all buccal bone was lost. And these results are particularly significant if we consider that in the aesthetic area of maxilla, the buccal cortical bone thickness is in almost the totality of cases less than 1 millimeter, and in almost 50% it's less than 0.5 millimeters. So, what does it mean? How these considerations can modify the timing of implant placement and our overall post-extractive implant strategy? Okay, now let me start from the beginning. One possible therapeutic option indicated for every post-extractive site irrespective to topography and bone condition. And really, the most frequent and popular technique in literature is the delayed post-extractive implant, the type 2 or 3. This technique was described in 90 years with a few clinical case series and prospective trials with follow-up within 2 to 5 years. From a prognostic point of view, this approach shows a high implant success rate with limited incidence of peri-implant soft tissue recessions. And these therapeutic options consist of a soft tissue healing next to a flapless automatic extraction after a 2-4 months healing period, and it allows to obtain soft tissue healed and thicker, a partial bone healing, especially at apical level, and the theoretical reductions of bacterial contamination. And But be careful, because according to the consensus report of the 15th European Workshop in Periodontology in 2019, only scarce evidence regarding this topic is present in literature. In fact, the trials have involved only a restricted number of experienced clinicians in a limited number of very highly selected patients. What does it mean? The results cannot be generalized to all clinical office. So, anyway, we can face two possible scenarios. The first one, where the buccal cortical bone is very thick and with a very low resorption pattern. The implant insertion is easy, similar to a conventional modality, and depending to bone quality and primary stability. Tooth position in the arch and the occlusal scheme, we can provide immediate or early function. And this is my clinical example case done up 20 years ago, when I usually use the type 2 post-extractive implants. We are at premolar area. At the time, Francesca was 45 years old. Not periodontal problems. She was in supportive periodontal therapy with 6 months controls, debridement and deplucking after an active therapy limited to restorative dentistry. 2 months before the visit, during summer vacations, she broke 1.4 tooth that was extracted by a colleague. We are in a static area. So I scalloped a full thickness flap, and we can notice a very thick buccal cortical bone. In this case, we know that the bone resorption would have been very, very low. So I inserted the implant longer than I would be now, and with the 2-stage technique. Again, now I would insert it with the 1-stage approach. Then I close the flap very accurately, and I waited for at least 3 months before a 2nd-stage surgery without any hard or soft tissue augmentation technique applied. And then we can see a temporary crown, then the definitive crown, and the situation after 1 year, and after 20 years, the hard and soft tissue stability from a clinical, X-ray, and perio point of view, more than 20 years after surgery. Okay, the second clinical situation is when there is a buccal cortical bone very thin or a post-extractive site very damaged due to the condition of the extracted tooth. In this case, we can expect a high resorption pattern at the site and almost always the need of a hard and eventually soft tissue augmentation. This is an example. We are in a super aesthetic area. Giorgio came to my office a few years ago when he was 7 years old. His dentist extracted his 1.1 tooth 3 months before, applied a beautiful splint. At the moment of my visit, the area showed the result of many battles of tooth surviving. And after removing the splint, the patient received steps 1 and 2 periodontal therapy according to the guidelines of therapy of periodontitis stages 1-3, and in only a few hours, a temporary mobile partial prosthesis for improving aesthetics. And after first periodontal non-surgical therapy, I did bone augmentation using deprotonized, demineralized bovine bone, mixed 50% with autogenous bone and covered by a collagenous membrane without any implant insertion. In fact, the site was so destroyed for allowing a correct insertion of 1 implant at the moment of GBR technique. It obviously means an elongation of therapy time and an increase in financial costs. And after 6 months, I removed the temporary Maryland bridge that I did before, and I inserted 1 implant prosthetically driven in a very more favorable site than 6 months before. Then applied a temporary crown for a few months. And so we can see the preoperative and postoperative with the temporary and definitive crown. But so we know that implants type 2 are predicatable and well-described therapeutical approach in literature. But when we can decide if and how extract a tooth, do you have other possible options? For example, the type 1 implant could be a good option for Francesca. An immediate implant could be an appropriate solution and without risks. And for Giorgio, being able to extract the tooth, would we have been able to reduce the buccal bone resorption really very high 3 months after extraction at the moment of the surgery? Using an alveolar ridge preservation approach, would we have been able to avoid or at least reduce the amount of bone augmentation at the moment of the surgery reducing the complexity of the approach and the risk of complication, the chart time and economical costs. So, when possibility is the immediate implant type 1, and when we insert a type 1 implant, we have a few disadvantages because it's a challenging technique for primary stability and management of mono-implant gap and per-implant for soft tissue seal. On the other hand, there are also many advantages for patient and for the clinician because the less chair time, less costs, and an increase in patient comfort naturally. So, in terms of prognosis, in a very well-known systematic review by Lang and co-workers published in 2012, we know that the survival implant rate for immediate implants is similar to early or conventional implants. And these results have been confirmed by more recent clinical studies with follow-up of at least 5 years or more. We still that the immediate insertion of a post-extraction implant in itself is unable to prevent the physiological post-extraction site remodeling. So, in terms of predictability and success, based on objective aesthetic parameters, 80% of immediate post-extraction implants show satisfactory results. However, they are associated for a higher frequency of vestibular margin tissue recession compared with early post-extraction implants types 2 or 3. The frequency of buccal recession soft tissues of soft tissues after type 1 implants is tending to decrease over time, probably as the results of better knowledge of aesthetics risk factors, of indications, and efficient application of a clinical protocol. And so, when do we do an immediate implant without risks? According to the consensus report, we can do it in patients and sites with low aesthetic risk profile, in sites with thick phenotype and buccal cortical bone integrity, and in single teeth, upper or lower, from 5 to 5. And from a clinical protocol point of view, nowadays we don't know if a clinical protocol is better than another one. Anyway, the best results as cumulative survival implant rate and per-implant soft tissue stability are described with a so-called three-modal approach. It was preliminary proposed in case reports and case series at the beginning of the new millennium, and then it became richer of new procedural aspects
I think we've just lost the professor. I think maybe his connection is a bit poor. We're just going to wait for him to log in again.
Sorry, I don't know why. Are you okay now? Is
Yeah,
okay now?
yes, we're okay.
Okay.
We're just
Okay,
waiting for your
so
screen.
okay, sorry for the Wi-Fi problem.
It's all right.
Okay. Okay, so I share with you. Uh, I I need the ability. Okay, now it's okay. Okay. Mm, I don't find my presentation now. Okay, this is okay. So we are here. Here is okay. So this is the protocol, and okay, okay, and so but now, what are the most significant biological principles and clinical factors? We meet Giovanna when she came to my office a few years ago. She was 5 years old, and she had an aesthetic problem on her one fourth tooth with an endodontic problem and with a very short root. So I decided to extract the tooth and substitute it with an immediate implant and immediate not functional loading. I did the extraction very gently with an automatic flapless approach. Literature shows that this approach is better than the flap approach in terms of next buccal tissue recession. The second uh, clinical factor is the respect of the bone implant gap, at least in the most coronal part of the buccal wall of 2 millimeters. This is crucial to avoid a subsequent compression of bone reducing buccal tissues stability. And another clinical factor is the bone graft DDB replacement in the bone gap, especially in the buccal site. The function is to facilitate the coagulum stability at the early healing phase and to compensate to the horizontal crest resorption. And this property is especially established in sites with buccal cortical bone plate lower than 1 millimeter. In a RSCT trial by Sanz and co-workers published in 2017, the crest reduction was significantly lower in the test sites compared to the control sites. These results justify the use of a particular graft in presence of thin bone, reducing the risk of next peri-implant soft tissue recessions and increasing the indications for immediate implants. One more crucial clinical factor to maintain the soft tissue stability, apart from automatic extraction and management of bone gap, is to incorporate an immediate temporary crown without occlusal contact. This crown is screwed and built by the dental technician in a few hours after a conventional impression immediately after the implant insertion. It's very important that the emergency profile allows tissue support without compression, and obviously, in this aspect, the role of technician is very, very crucial. So, sorry, okay, and 3 hours after the surgery, I incorporate the temporary crown, and I didn't modify or move the crown until 3 months later, when I look a new impression, the definitive impression, and in one only session, I can incorporate the definitive crown. Please notice the interdental papillas and the soft tissue and hard tissue health, and this is 3 years later. Please look at the stability and the beauty of the peri-implant soft tissues. And here are the results and the comparison among pre-op, immediate post-op definitive crown, and 3 years later. Using this approach, I can show you a lot of long-term clinical cases. For example, Gabriele, to whom I substitute a 1.1 with a type 1 implant and immediate temporary crown, the definitive, and 10 years later. And Enzo, who lost a 2.4 and I substituted it with an immediate implant with a temporary crown, the definitive after 3 months and 10 and 12 years later. And Silva, to whom I substitute a 1.5 with a type 1 implant, temporary crown, and definitive 3 months later and 12 years later. And Adelmo with a 1.4 and the same good results after 12 years. But, so if we adopt a stringent clinical protocol, even if marginal tissue recessions are possible in a few unfavorable sites and patients, we can assume that the post-extractive immediate implant can be a predictable and appropriate treatment in favorable situation concerning to the indication, the risk factors, and the adherence to the protocol. Anyway, it doesn't represent an easy approach, especially to inexperienced clinicians. Now, the problem is, what do we do when we don't have ideal site conditions or in patients who present risk factors, especially from an aesthetic point of view? To answer to this question, together with a lot of the clinicians, I was involved in a prospective multicenter clinical study published 2 years ago on JOMI with a few main features. A follow-up of 2 years, 15 clinicians, 214 implants type 1 with always a not functional temporary crown in an upper or lower aesthetic area from 5 to 5, and very important, not exclusion for systemic on local risk factors for implants or aesthetic. The only exclusion criteria was not rated periodontitis or primary implant stability less than 35 Newton per centimeter. And the potential risk factors were out of 116 patients, over than 50%. The principal aims of the study have been the clinical evaluations of failures, implant failures, buccal soft tissue recession or other complications, soft tissue evaluation according to Pink Aesthetic Score, and patient satisfaction from an aesthetic and functional point of view using a VAS scale in a patient-centered investigation. What were the results? First of all, there was a very high early failure incidence for 15% within the first 3 months, but only one late failure. The failures involved 2 centers only, with a strong centrum effect. So it means that few clinicians had a cumulative survival rates of only 60%, while all the others had high success rate. And so the clinician role is very, very significant. Another important result was that no statistical correlation has been recorded between failures, clinical experience, and risk factors. Then, only 6 resections at 2 years have been recorded by the clinician, but not detected by the patient. And very interesting, no resection involved patients without risk factors. And last but not least, high levels of personal satisfaction, both aesthetic and function, resulted with very close to 10. So, now look at one example case. Marinella, female, 46 years old. When she came to my office,
I guess we will have to wait for the professor to log in again. May we please just be patient with him?
Sorry, I'm changing my connection now and I hope it's better. Is it okay for you?
Yes, it's now okay, Professor. It's now okay.
Okay, I'm sorry, I'm really sorry. Okay, now this is Marinella. And so when she came to my office sent by her dentist, she had a problem, and the diagnosis was vertical root fracture, and it was mandatory the tooth extraction. Anyway, she was worried about a possible aesthetic discomfort. So I evaluated the aesthetic risk profile and I noticed that she had a high risk from an aesthetic point of view for an immediate implant because she had higher aesthetic requirements and a high smile line and very crucial, the position of the marginal buccal gingiva of the lost tooth was apically respect to the contour of the adjacent teeth gingiva. Moreover, the gingival phenotype was very thin with a gingival cleft and also a frenulum and probably, even if in this case a CBCT has been done, with a clinical evaluation, the buccal bone appears very thin, and then intrasurgically, I noticed a buccal fenestration too. So I did an automatic extraction flapless, maintaining the interdental tissues. Then I inserted an immediate implant with incorporating a temporary screwed crown. And here we can see a short clip we can notice that the periodontal probing and only visually we can see 10 millimeters of periodontal of depth. So there is a vertical root fracture. So I extract the tooth and the need of something as temporary prosthesis. So it's very important to clean the post-extraction site very well. And then I chose the implant and I reached a very high primary stability. Okay, so we can see the insertion of the implant. Then in the bone implant gap, I inserted bone granulate graft and then I took an impression, then I sent immediately to my dental technician. And after only a few hours, I received a temporary crown to screw to eliminate the occlusal point is a very important because it is crucial for the first 3 months of surgery to avoid occlusal contacts in centric and during the eccentric movement. And so, in this picture, immediately post-surgery, the temporary crown, and 1 week later, 1 month later, the situation is improving. Then 3 months after surgery, and a few weeks later, at the moment of the definitive crown by my colleague, with the comparison to before, then after 2 years, after 5 years, and then after 9 years. And so, what does it mean? This very favorable result means that in this case, or in similar clinical cases, if you apply a stringent clinical protocol and you know biological principles, you can use the post-extractive type 1 implant even in unfavorable situation with risk factors. Anyway, in this moment, in this moment, although there is the need of new clinical studies, and now, although I'm really comfortable in type 1 post-extractive implant, according to the last consensus report, workshop in periodontology, the indication of immediate implant placement are as possible option for tangible patient benefits related to shorter treatment time and cost efficiency. Anyway, the indications should be limited to sites and patients at low risk, non-aesthetic areas, intact alveoli, thick and flat periodontal phenotype. So, sorry, one moment. Okay, so when advanced techniques of hard and soft tissue augmentation meet, and when there are so severe post-extractive alveolar defects, in this case, and when it's very difficult to obtain a good primary stability of the immediate implant, for example, at molar sites and in very compromised sites, especially in very aesthetic areas. In all these cases, what is the best post-extraction implant strategy? Obviously, we can delay the implant insertion, but can we do something for reducing the need and the complexity of the augmentation techniques when we inserted the delayed implants? So, in this case, the literature presents clinical recommendations regarding the alveolar ridge preservation. This term includes all the techniques useful to obtain a preservation and partial reconstruction of the alveolar ridge, depending on the integrity or partial damage of the post-extractive site. The clinical recommendation clarify that ARP techniques are useful to maintain the volume stability of the implant site and to optimize the functional and aesthetic outcomes and to simplify clinical procedure following alveolar preservation. And the rationale is not to increase the possibility to insert an implant in a post-extractive site. This is possible also without ARP, but to assure that ideal implant placement, reducing the need of bone augmentation. The consequences of it are a reduction in biological costs in terms of morbidity and complications, and in a reduction in economical costs, limiting the number of surgical procedures and biomaterials. About the efficacy, Avila Ortiz demonstrated in RCT on 53 patients published in 2020, and with one implant in a test seat, in one implant, that in test sites, ARP technique at the moment of extraction reduce necessity of GBR more than in control sites without ARP technique. In terms of clinical procedure, in literature, a lot of techniques are described. We can report two types of it. The first one concerns in an automatic flapless extraction, particular granulate graft of DDBB, and use of a free epithelium connective graft sutured. The second option is to use, after the automatic flapless extraction and the application of the bone graft, a collagenic sponge sutured. In this case, pushing very strongly the collagenic sponge is crucial to avoid its resorption before of 10-15 days. This technique, obviously more comfortable for the patient, has been described in a few RCT trials. In the ARP clinical procedure of Lucas curettes is very, very important. We have to utilize 3 sides of them to assure a complete degranulation of a post-extractive site. The complete elimination of soft tissue inside the post-extraction socket is crucial for allowing a complete incorporation of the bone granulate graft and for stimulating a bone conduction in the early phases of healing. And now we discuss about the indications for ARP. The first one is the treatment of an upper molar close to the maxillary sinus, and we meet Mario, a male 67 years old, who usually comes to my office for supportive periodontal therapy with professional instrumentation 4 times per year and a periodontal reevaluation once per year with complete periodontal probing. During a session of SPT at X-ray control, we have noticed a deep caries at bifurcation and the 3rd grade in the 2.6 tooth with an incipient apical lesion. The patient claimed pain after chewing food. 20 years before, the patient received a periodontal therapy as non-surgical before and then corrective surgery. We noticed that in the anterior area of the upper jaw, I used a conservative surgical approach with papilla preservation technique, and in the posterior upper and lower areas of the jaws, I eliminated the vertical components of the pockets with a resective approach and for bifurcation lesion, I adopted a tunneling technique in the mandibula and only maintenance of the interradicular horizontal defects. This approach has allowed to maintain teeth for 20 years in a patient with a good oral hygiene and compliance. After then years, I decided to extract the tooth and substitute it with an implant. Would waiting for a spontaneous healing have been a good idea? No, I'm sure it wouldn't. And this because Levy and co-workers RCT shows that ARP technique reduced sinus pneumatization and crestal resorption after tooth extraction. Another RCT at 9 months by my friend Giulio Rasperini shows that our technique increases possibility of placing implant without a sinus lift. And so I decided to extract tooth and apply an ARP technique. After 4 months, we noticed the site without horizontal contraction, and I was able to insert an implant in a one-stage modality and with a really good primary stability. Here we can see the temporary crown incorporating on the implant, and please note the ability of the patient to maintain a good interradicular hygiene at the closed tooth. And so we can see the definitive crown and the complete situation of periodontal reevaluation. So one more indication for ARP is the implant insertion in damaged post-extraction sites. And we meet Cesarino, a male 69 years old with no systemic problems, no smoker, and in supportive periodontal therapy since 1997. During a SPT session, we have intercepted a vertical root fracture, probably created many weeks before my visit. So I extracted the tooth and I noticed a complete absence of the cortical buccal plate as a result of the inflammatory reaction to the root fracture. In this case, it wouldn't have been a good idea to insert an immediate post-extractive implant because the deep discence would have been a problem for maintaining a peri-implant tissue's stability. This is instead a very good clinical indication for ARP technique. So, this is the situation at the end of the surgery. And 4 months later, this is the X-ray and the clinical situation. And we can see a good response in healing and the situation before and after the implant insertion. Note the good ridge profile compared to the preoperative situation. And here, with the prosthetic crown and okay, finished. And now we meet Piero, male, 73 years old. The patient, until 2 years before these clinical records, has had supportive periodontal therapy every 3 months, but for a long time, he didn't come to my office because he had assisted his wife who died of cancer. He came back with a 2.1 tooth hopeless. We can see the deep pocket, mobility, and buccal loss of clinical attachment level. I decided to extract the tooth with an automatic and flapless approach and did an ARP technique with the use of particular bovine bone graft covered by a soft tissue graft. Okay, And this is the situation after 4 months from a clinical and two-dimension X-ray point of view. So I decided to do a CBCT of a site in which we can see a complete maintenance of the bone profile and clearly visible few large bone grain. So I opened a flap incorporating the interdental papillas, insert the implant prosthetically driven, and after an intraoperative impression for having a temporary crown within 4 hours, I inserted a connective graft to increase the soft tissue thickness. So we can see a short clip concerning this surgery. So this is the flap incision, a simple incision in the middle of the crest and comprehensive the interdental papillas, and with the sub and circular incision. So I open a thick flap, as we can see, and this is the new bone formed. And so prosthetically driven, I can insert the implant very carefully. And so this is the preparation of it, very carefully. And then I insert the implant with a very good primary stability. Then I fixed only temporarily the flap, only to take an impression, a normal, usual impression. And then I leave the first shooter, and then I prepare a connective graft taken off the palate, and then I introduce it in the flap, and I add it to the flap with resorbable shooter, and then I close very accurately the flap. Okay? And the dental technician built the temporary crown, copying the natural tooth with the same emergency profile. So after 24 hours, I incorporated the temporary crown, and this is the situation after a day and after 2 weeks at the moment of shooter removal. And this is the temporary crown, and 3 months before the definitive impression, and the definitive crown just applied. So we can see the preoperative situation and the postoperative situation, and the situation at 3 years post-operative. And so, after this last clinical case, I will share with you a few take-home messages. Post-extraction site management for implant placement comprises the application of various therapeutic options. The use of an alveolar crest preservation technique can reduce necessity and invasiveness of bone volume procedures, simplifying next clinical procedures. The actual evidence-based dentistry clinical recommendations suggest immediate implant placement by experienced clinicians in patients with a low-risk aesthetic profile, particularly in premolar zones, while in sites with high aesthetic relevance, it's suggested early or delayed implants. The use of a stringent clinical protocol that incorporates the use of an immediate provisional crown shows favorable results with regard to a reduction of aesthetic complications after the insertion of a post-extractive immediate implant, even in the presence of aesthetic risk factors. So I want to thanks my colleagues, assistants, and secretaries of my office, and obviously thank you for your kind attention. And now I am ready if you want for a few answers, if you want. I'm here.
Thank you very much, Professor, for the wonderful lecture. We really appreciate your time. So I would like to give to the floor anyone who has a question. I guess maybe we just have to look in the chat box.
Yeah.